Hello, everyone. Well, welcome. And today we're talking about a topic that probably is quite familiar to everyone. And if not, you will definitely be more expert as we get towards the end here. So, COPD is a common preventable disease, and it really manifests in many different ways. We will delve in deeper as we move forward, but about every year, the definition slightly changes, and we'll overview the latest definition as we progress today. So I have no conflicts of interest to report, although certain products, devices, or even medications will be discussed within just the scope of COPD management in general. So to be clear, I am a respiratory therapist, not a medical doctor, and hopefully all on today's call can utilize the information presented irrespective of where you're working and what environment you're in typically. Our goal is to ultimately enhance patient care of all patients, but particularly today, those with COPD. So just three simple objectives to keep us on track today. Hopefully, we will do all of these efficiently and to the full capacity. We're going to identify the purpose and goal of the COPD guidelines. They are quite a detailed document as it would be, and every year, of course, they do an update. Some are more intensive than others. This year's update wasn't quite as much as arguably the last couple of years. But anyway, number two here, we're going to discuss the assessment diagnostic aspects of COPD. And then near the end, we're going to actually practice by categorizing patients according to the GOLD guidelines. And we'll brush over some treatment strategies for stable and also not so stable COPD, which are more of the exacerbation category. So the most recent comprehensive document is shown here, updated just for 2026, and it has now grown to almost 250 pages, 248 to be exact. There is a more concise summative pocket guide that is just under 70 pages. So to give you a bit of perspective, the so-called Global Initiative for COPD, also known as GOLD, is made up of a board of directors and a science committee, as well as what is known as a GOLD Assembly, which includes leading physician scientists from various aspects of the world. The goal here, the GOLD group revises these standards or this report every year, and it really is a tool with the primary purpose to provide exactly that, just a tool to implement effective management programs based on local healthcare systems. So, of course, you would tailor the information to where you practice, and we know that sometimes there is a lag between the evidence that is released or agreed upon by experts in the field and then their implementation thereof at bedside. There can unfortunately be quite a bit of a delay. And it's not a lot you can do about that except just help to champion some of this new information out there at bedside. That said, according to goldcopd.org, this is the website that provides the world-renowned GOLD guidelines. The Global Initiative for Chronic Obstructive Lung Disease, or GOLD, works with healthcare professionals and public health officials around the world to raise awareness of chronic obstructive pulmonary disease and also to improve prevention and hopefully treat the lung disease with better knowledge and more purpose and direction. So through the development of evidence-based strategy documents for COPD management, and they have events such as the annual celebration of World COPD Day, GOLD is working to improve the lives of people with COPD in every area of the world. You can see from this bulleted list here that the GOLD guidelines, they serve several purposes. Arguably, the most important of those listed here is probably to decrease morbidity and mortality from the disease, to slow down the disease progression, the burden thereof, and to certainly prevent death that is associated with COPD and the overall COPD condition. Mind you, so-called programs can be just about anything that is implemented to be effective in decreasing disease burden. Whether you're heightening awareness overall, and certainly if you're talking about adequately treating patients to prevent exacerbations, that would be a key point here. So the goal is, yes, to decrease morbidity and mortality, but there's a lot to discuss in between each of those. And of course, the program is what you're able to not only implement, but sustain. And hopefully it is an effective program that you're constantly reassessing, whatever that program may be. So you can just Google Gold COPD or go directly to their website, goldcopd.org, and you can quickly download PDF versions here of either the full report or the more abridged pocket guide. On the webpage shown, there's usually advertised an annual Gold International COPD Conference, and it's typically in Philadelphia, Pennsylvania each year. There's also an official COPD Awareness Day that is annually. I highly recommend this pocket guide. Its PDF version can go on your smart device or your tablet. Certainly your work computer would be a really good thing to have. And if you don't know about Command F or Control F, where you can search a particular keyword, that's something that's very useful in these larger documents. There are many other resources among their web pages aside from just the pocket guides and the summaries. I mean, they even have PowerPoint slide sets. They have an app, and they even have podcasts that are available if you really want to nerd out on COPD. And who doesn't want to nerd out on COPD? I mean, most of our patients that we care for, I would say the lion's share have COPD if you're in respiratory therapy. We will concentrate primarily for today's topic on the most updated report, which is 2026. Since last year's report, the concept of monitoring, which we are aware is ongoing regardless of what area of the hospital you're in, but monitoring has been added to Chapter 2. And comorbidity has been changed to multimorbidity. And I think you're going to see more of that as a buzzword in the years to come, rather than just comorbidity, multimorbidity. That's in Chapter 5. And there's a new Chapter 6, which has AI, the emerging technologies that's just come out here. And worth emphasizing, vaccination recommendations for people with COPD has also been updated. And you've got this new section on disease activity that's now included in the report. And so for chapters 4 and 5, there's been a complete revision of exacerbations of COPD topic and multimorbidity. A bit later, we will dive into the so-called treatment objectives, which is really what steers everything once a diagnosis is made. So here is the latest global definition of COPD. And according to the latest Centers for Disease Control statistics, chronic lower respiratory diseases, mainly COPD, is currently the 5th leading cause of death in the U.S. However, in the latest Gold COPD report, it is emphasized that COPD is now one of the top 3 causes of death worldwide. Now, the CDC are due upcoming to update their COPD stats, but currently, this is just according to the latest released numbers. There are just over 4% of adults in the United States that have ever been diagnosed with COPD, emphysema, or chronic bronchitis. And I mean, this is staggering. More than 145,000 Americans die each year of COPD, and that's about 1 death every 4 minutes. The main risk factors are probably familiar to everyone on the call today: tobacco smoking, or being around tobacco smoke, and it can even be third-hand smoke, which is usually in the areas around the person smoking that it infiltrates and it soaks into carpets, drapes, couches, sofas. You've got outdoor pollution, indoor pollution, and also occupational exposures. In the current Gold COPD definition, you can see there is an emphasis on bronchitis and emphysema. Chronic obstructive asthma, however, is not mentioned. Now, although this definition is verbatim from the latest 2026 Gold COPD report, its original release, you can see there at the bottom of the screen, its original release was in the American Journal of Respiratory and Critical Care Medicine in 2022. So they really haven't changed the definition all that much. The Gold Science Committee prepares updates to these documents every year, which are made available on the Gold website as they're completed. And the Science Committee uses a very sophisticated set of procedures to review the world's literature, can you imagine, with regards to COPD diagnosis and management, and to update the documents to reflect this so-called state-of-the-art information. Now, of the changes in the new report, there are several important updates, including, as I mentioned, a new section. You can see Chapter 6 there at the bottom. So in particular, Chapter 4 and Chapter 5 have each been completely updated, but there is a lot of new information, not just a revision that is included in the latest version. And I've teased out just some of the main items on this slide. As mentioned earlier, interestingly enough, here we have it. We have a new Chapter 6 on artificial intelligence and emerging technologies in COPD. And I highly recommend taking a look at that. It doesn't really get granular or specific, but it still alludes to where we're headed. If you're a respiratory therapist or any healthcare provider on the call today, you certainly see patients presenting with symptoms of shortness of breath, cough, and increased sputum production. These are very common. A chronic cough is usually defined as a cough that lasts for 8 weeks or longer. And with COPD, particularly the moderate to severe or end-staged patient with COPD, a persistent cough and recurrent exacerbations are unfortunately just a part of that patient's everyday life. The main risk factors for developing COPD are shown here. And you can see, yes, tobacco smoking is a part of that, and it's the main risk factor. It still tops the list. But you also have genetic predisposition that is still a likely cause, although many years of research reporting suggests that an individual effect size is really small for genetic predisposition and for predicting the development of COPD. And you really just cannot predict the genetic predisposition unless there is specific genetic testing, and most patients just don't have that. Worth mentioning, there's also the potential for COPD with asthma or COPD and asthma. Particularly in childhood, asthma that is poorly controlled, they may end up with lung remodeling. Also, there is always the possibility of what is considered COPD of unknown cause. This is a never smoker. This is someone who has no known exposures to particulates in the environment or some sort of occupational exposure. They just don't know why they're having symptomology. They present, maybe they get a PFT, a chest x-ray, and everything points to COPD. So that's still a possibility. There's this relatively new way of viewing the COPD condition in that, as shown here, you have patients with COPD-like respiratory symptoms that do not necessarily have airflow obstruction that qualifies as COPD. And we're labeling these patients pre-COPD. Now, there's a newer term in the last few years. You've seen it probably in the literature. Certainly, it's been part of the GOLD guideline. The term PRISM. PRISM stands for Preserved Ratio Impaired Spirometry. And it's really the patient that may have abnormal spirometric values, but they don't meet that criteria of having an FEV1 to FVC less than 70. So notice, although patients that fit the pre-COPD or even PRISM criteria are at higher risk of transitioning to a full COPD diagnosis, it doesn't guarantee they will. Not everyone worsens to that degree over time. Now, let me be clear before we move forward, spirometry is an absolute must when attempting to diagnose, to classify, and to manage the COPD condition. And aside from clinical history, spirometry is one of the quantifiable metrics to allow really a definitive diagnosis. You can't really say someone absolutely has COPD if they've not had spirometry. It's interesting, though, you and I always see these in the medical record, or they've been told they have COPD, and there really isn't much that points to it except they had a little bit of a cough, they presented, maybe their chest x-ray was somewhat abnormal, but they really did not have the overall COPD criteria to meet the diagnostic. You can see that COPD patients, as expected, they have indication of airflow obstruction on simple spirometry with that FEV1 to FVC ratio, also known as FEV1%, less than 70. There it is at the very top here. Notice this is post-bronchodilator. Recall that certain obstructive diseases, such as asthma, are fully reversible, but true COPD is only partially reversible at best. It is a literal chronic obstructive pulmonary disease. Spirometry is still considered the most reproducible and objective measurement of airflow obstruction when it is properly performed under ideal conditions, and we know it always is not necessarily the case. A reminder of the main goals of COPD assessment. Ultimately, a diagnosis must be established, and thereafter, of course, an effective treatment plan is really the ultimate goal. You can see that therapy course is going to be guided by the COPD assessment. And a lot of times there can be a predictor of whether they're going to become exacerbated or whether they're going to be that frequent flyer. Unfortunately, sometimes you can know what needs to be done and you can make recommendations to the patient, but it's very difficult to get them out of that environment that they're exposed to. Patients have tried to quit smoking multiple times and failed. It's a very complicated process, as you're very familiar with. And yes, smoking is a main risk factor, but when best described per the COPD Gold Expert Committee, COPD is influenced by both genetic and what are known as epigenetic factors. Basically, genetics loads the gun and the epigenetic factors pull the trigger. So you can have somebody, for instance, that is at risk for diabetes, familial history, but they have a diet and lifestyle that's fighting against developing diabetes. They may not develop diabetes. So not everyone that smokes will get COPD, and not everyone that has COPD has smoked. But most will likely develop obstruction if they smoke long enough. But some of the most severe cases of COPD I've seen have been non-smokers. Genetic predisposition is not always easy to predict, but it's powerful and impactful to disease development when it is present. It's just difficult to pinpoint. All of these comorbidities, or should we say multimorbidities, with the new guideline vernacular, these should be actively sought out and treated appropriately when present. These can all influence mortality, hospitalization, certainly independently, and health status. Independent of the severity of airflow obstruction due to COPD, these are the major impacts over these conditions that bring someone into the hospital that maybe not as a pure COPD exacerbation, but they end up being a more complex course of care because they also have COPD. Here is shown what is known as the MMRC. It's labeled there at the top, the Modified Medical Research Council Dyspnea Scale. That's a mouthful. This is a patient self-rating tool where the goal is to assign a number or a grade category to both qualify and quantify a person's breathlessness during their everyday activities. Now, it could be viewed as a surrogate for indicating quality of life or even implying level of activity of daily living, but it really is just relating to their level of breathing difficulty. It's a simple tool that scores from 0 to 4. 0 represents breathlessness only during strenuous exercise, which, heck, don't we all get breathless when we're doing strenuous exercise? And then a number 4 would indicate being too breathless to leave the house, or maybe even breathless when just dressing or undressing, doing your normal activities. You can see from the citation included here, this test has been around for almost 45 years, but it is still endorsed by many professional organizations, including the latest Gold COPD guidelines. So the original citation is from 1982, which, wow, what a great decade, the 80s. But you have the copyright of 2026 there at the bottom. It's included in the latest guidelines, still around. It's a great test. It's been well validated. Here is shown the COPD assessment test, just affectionately known the CAT assessment. This tool, after many years being known as the COPD assessment test, CAT, has now been renamed this year as the Chronic Airways Assessment Test. So it's still CAT, but with 2 A's. So the new CAT, the updated label for it, the test isn't really that different. It's not different at all, actually. The CAT attempts to qualify and quantify a degree of happiness or sadness centered upon their overall symptomology. Notice the scale here is from 0 to 5 for each question, with the total possible score from 0 to 40. Now, the higher the number, the worse the condition, just like the MMRC test we just looked at. So this CAT score is also known as a COPD impact score, where anything 10 or above considers COPD to have greater than just a low impact on the patient. So when they hit double digits, it's an indication that COPD is really beginning to interfere somewhat with their life. Both the MMRC and the CAT scores are accounted for on what you're seeing here, a more all-encompassing tool known as the newly updated ABE assessment tool. And I know it's a lot to take in on a 1 hour webinar here, but the ABE tool offers a model for the initiation and the steering of pharmacological management of COPD according to the individual assessment of their symptoms and even their exacerbation risk. You can see on this tool here that spirometry results are included to allow a grading from either a category gold 1 all the way to a category gold 4. And you that use the gold ABE assessment tool regularly, just keep in mind there was a revision to this scoring system for the 2026 release. And I know there's always a bit of a lag between what is released in the literature and sometimes what we see at bedside, but just do keep in mind it has changed. It's been updated. Now, the St. George's Respiratory Questionnaire still remains the most widely documented comprehensive measure, but what I'm showing you here, the MMRC, the CAT test, the GOLD ABE assessment tool, this is kind of a quick summative version of how to get to an endpoint of classifying a patient without much of that longer document. Here's a short list of updated recommendations to what they're calling maximizing the COPD patient's quality of life. And I want to particularly call out that despite various low-level articles that might discuss e-cigarettes as even maybe a tool for tobacco smoking cessation, page 21, I have it referenced here, page 21 of the 2026 Gold COPD Pocket Guide states, there is no evidence to support the effectiveness and safety of e-cigarettes as a smoking cessation aid at present. So that's the consensus. As expected, vaccinations are still recommended, as you can see here on the list. And even though vaccines in general have become a particularly hot topic as of late, per the consistent research findings, flu and pneumococcal vaccines, as well as even RSV vaccinations in certain COPD patients, are still shown to decrease incidence of lower respiratory tract infection. This is what is going to allow the patient to potentially not be exacerbated, not be the frequent flyer, keeps them out of the hospital. So we still recommend patients to get their vaccinations. Just some additional considerations to maximize the COPD patient's quality of life. You cannot discount the importance and the merit of long-term oxygen therapy. Long-term oxygen therapy has been shown to actually improve survival. That means to lengthen someone's life for patients with severe resting hypoxemia. Those are the patients that are below the 55 TOR, certainly below 60. If they've got cor pulmonale or secondary polycythemia, these are the patients that benefit the most from long-term oxygen therapy. For patients with severe chronic hypercapnia or a history of hospitalizations for acute respiratory failure, long-term non-invasive may decrease hospitalizations and prevent rehospitalizations. I know you don't want to put a COPD patient on the ventilator if you can avoid it, but BiPAP, more so than being intubated, is still preferred if it does what it's supposed to do. Now, for select patients with advanced emphysema refractory to traditional therapies, you even have the option of surgical or bronchoscopic interventions that may be beneficial. And then, unfortunately, some patients with end of life or they're come to the end here where we've exhausted the therapies, palliative approaches to care are important. Remember that goals for treatment of stable COPD are simply to reduce the symptoms and to reduce the risk of worsening and exacerbation. Research has suggested that a majority of patients actually want to quit. Even if they want to quit smoking, they are going to require multiple attempts, 5 to 7 times. Some research suggests many more tries before they have success in quitting smoking. And we know many will need help, like nicotine replacement therapy, in order to quit smoking. So before we delve into a bit of overview of treatments, the premise of all therapies to be discussed upcoming is that the patient has been graded and classified into either A, B, or E category. A being the least at risk, A meaning doing pretty good. Last time I checked, an A was good. And then E being the greatest risk, therefore needing more extensive treatment and prevention strategies. So just keep that in mind. The goals for treating stable COPD, again, reduce symptoms and reduce risk. Without going into the extensive therapies and the multiple charts that guide medication use, I want to overview just a simple point or two here. We'll just call them summative points. Typically, single medication use, also known as monotherapy, is considered inferior to the use of combination medications. And I know both caregiver and patient alike, they get frustrated because they're on all those inhalers or they're on this medication where there's several medicines in one. But this is what has been shown as more effective than just the monotherapy. And although it is recognized that a single inhaler therapy may be more convenient and therefore more effective because of availability and the patient's going to be maybe even more compliant than combination therapy, you cannot say that monotherapy works as well as the multiple layers of therapy, what we call triple therapy sometimes, some of the newer medications, and I'll avoid brand names here today. Notice for the low symptom, low risk group A category of patient, a simple bronchodilator is indicated. For the higher risk patient with COPD related multi-symptoms, that would be like the group B category, the use of combination of long-acting beta agonist and long-acting muscarinic antagonist is recommended. So we're adding layers to their therapies. And for the highest risk for exacerbation, that's the worst case scenario, the group E, there's the additional consideration of even adding in inhaled corticosteroids, which is an anti-inflammatory, if they have what is known as peripheral eosinophilia. So their eosinophil count is high in their blood. That usually means they're more predisposed to allergic reactions, allergies, just systemic inflammation. Notice for group A and B here that the exacerbation history per year has been updated to 0. And for group E, we're assuming they at least have one, if not more, moderate to severe exacerbations in the previous year. So from here out, really only the group E patients would be considered frequent flyers. Today's topic is not meant to present a comprehensive dive into COPD treatment. That's not why we're here. We're not going to delve deep into pharmacologic interventions, but it's worth mentioning that so many more medications aside from just traditional bronchodilators may be indicated or optional dependent upon the patient's current state or symptom history. I know albuterol, everyone loves albuterol, and yes, it can be very effective, but it's not the end-all be-all. It doesn't solve all the problems. You and I know this. Just to address a few other items of interest, good old theophylline, which many on the call are no doubt familiar with, is only known to exhibit a small bronchodilator effect in stable COPD with only modest symptomatic benefit. But I know some of those patients, they love their theophylline. The PDE4s, the selective phosphodiesterase inhibitors, these newer medications that you've seen proliferate onto the market the last 10 years or so, the anti-inflammatory effects of these PDE4s include suppression of cytokines. Those are those chemical messengers that stir everything up. So the PDE4s are very good at keeping down the inflammation, the inflammatory cascade. And these also inhibit the lungs from being infiltrated by all of these white blood cells. Pulmonary remodeling and mucociliary malfunction are also attenuated by PDE4s. They're very expensive, unfortunately. They usually require special nebulizers, so they're not really the front line, or I should say first line, but they are helpful. Remember that anti-inflammation is very important in COPD to reduce the risk of COPD exacerbations. Now, these PDE4s, these anti-inflammatories, they're not bronchodilators and therefore not indicated for the relief of acute bronchospasm, but they can be highly effective nonetheless. I know it's a busy slide. I realize it's a lot to take in, but there's no need to memorize the chart. And to my knowledge, there's no test on this chart at the end. So the reality is that physicians or mid-level providers will be managing the therapies and ordering all of the medications, but it really is the respiratory therapist, and in some cases maybe the RN, that needs to be able to administer these medications. So it's very complicated. You can see from this relatively comprehensive list that there are many options available, and likewise many formulations and therapeutic devices that exist to deliver these medications. COPD management, particularly the pharmacologic side of things, the medication side, is very complicated. But you're RTs. I don't need to tell you that. You experience this every day with your COPD patient medication cocktails. You're walking in going, well, they've ordered a new medication on you, sir. And, you just really, you're dealing with a lot of challenges. And think about the patient here. Here's a short list of the various treatments that are not always applicable to every patient, but nonetheless can be extremely beneficial in the niche COPD patient population for which these therapies are really indicated. Notice opioids are listed here as a potential treatment for dyspnea. I know opioids can suppress the respiratory drive, but in the latest GOLD guidelines, it made the list. You're going to see more and more of these non-traditional therapies come to market as newer evidence-based guidelines slowly begin to make their way to bedside. So prepare yourself for it. Wrap your head around this. Opioids, who would have thought it 25 years ago, right? So just to put it into perspective here, this is just a sampling of some of the inhaled medications currently on the market. Can you imagine being a patient and trying to traverse this landscape? Even as a respiratory therapist, as a clinician, I mean, this chart provides great insight into just the complexity of respiratory care for any patient population treated with inhalers, but could also be considered particularly relevant for our specific COPD patient because they're on a majority of these medications, or at least a majority of these medications are used to also treat COPD. Now, no doubt we've all seen charts like this similar, but it's no wonder that patients and caregivers, and let's be honest, even bedside clinicians are oftentimes confused on the what, the why, and how the heck do we deliver the medication properly? And if they're on more than one or two medications, what's the correct sequence? Which do I give first? But how did we get here when things started out so simple? Well, not too long ago, 2023, the AARC published their 5th edition of the Aerosol Delivery Devices Guide, and this is an exceptional resource for any clinician wanting to increase their expertise in order to better educate their patients. I would say most manufacturers make their package inserts readily available for viewing or download via PDF online, and you occasionally, especially in outpatient care, you come across less familiar aerosol devices, and there's just so many on the market. It's very helpful to have the package insert available, and you can download these on your device that you have with you at all times. But don't throw away the box. And it really is helpful to sometimes read ahead before you walk into the patient's room, take it out, and realize, it's been a minute since I've seen this device. I would assume that most on the call, with a little bit of experience, you're able to kind of traverse the landscape more than the average healthcare provider. We're supposed to be the experts, but hey, it's a lot of responsibility, and sometimes it can be a daunting task. Remember goals for treating stable COPD. Reduce symptoms, reduce risk. Here's a great summative slide of the main considerations in just the generalized world of COPD management. Notice in particularly the bottom right section of the initial management here. Today is not an acute care presentation on specific treatment of exacerbations necessarily, but just to reiterate, for all COPD patients, when possible, prevention is the key. And in my personal experience caring for COPD patients over the years, there are these prime opportunities once a patient is stabilized to really emphasize various self-management education that can make a real difference in their well-being in the long run. Now, it might take a very tactful approach in some cases, but we'll do what we can to help our so-called frequent flyers, right? And oftentimes, it's just that window of opportunity when they are exacerbated, they've come in, they've gotten treatment, they're somewhat stable, they're a little bit more open-minded to discussing what can I do to avoid this happening again. And you really just have to strike while the iron's hot, so to speak. Despite all the advances in technology and the emerging data related to biochemical influence over the COPD condition, yes, we know there is a very complex cascade of inflammation that is a part of the COPD condition. But guess what? Pulmonary rehabilitation remains a simple yet effective intervention. Notice that pulmonary rehab, time and again, has been shown to improve health-related quality of life overall and to even decrease hospitalizations. And notice it's recommended for not only the worst case scenario, which is ABE, E category, but also the B category. So both B and E will benefit from pulmonary rehab. There's so much to consider when caring for a patient with COPD, particularly when in-servicing the patient for the very first time on their new inhaler, or whether it's the 100th time they've used the device. Some of them think they know how to do it, and you and I know they do not, and they need re-education. So they are complicated. We have to take a bit of time whenever possible to truly assure our patients understand the indication for the medication and the proper administration technique. Buy-in is so important, as you know. And it may not be the patient buying in. Maybe it's the family member. You bring them all to the table. Take the opportunity as it comes available. A few more items of interest that may not always be front of mind, but important nonetheless. Diuretics, anticoags, the treatment of those comorbidities, which they are trying to transition into multimorbidity. And then the nutrition's important, and then trying to prevent thromboembolism. A significant portion of COPD patients are known to have pulmonary emboli. Now, smoking cessation there at the bottom as well. But these all depend upon the general clinical condition of the patient, of course. But smoking cessation always, 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 if they're smoking. Here is the most current list of interventions that prop up this recommendation management cycle. As respiratory therapists, we're likely very familiar with the various bronchodilators and inhaled corticosteroid regimens that are a mainstay of our daily routine in managing our patients' therapies, but we too often forget or may even overlook some of the evidence-based options for creative approaches to COPD management and care. Now, I realize you're not out there managing patients as the ordering provider, but a lot of times you're part of these teams and you have rapport with the ordering provider and the physician is asking for your thoughts. Especially if you're at an academic medical center, there is a large opportunity to collaborate. So there is a compelling body of evidence that vitamin D, of all things, may help regulate inflammation in the lungs, and that lower vitamin D levels are actually associated with risk of developing COPD. Little things like this. As things are updated, the points of view should change. So I'm not trying to inundate you with too much information, but here is a nice summary of some key points for managing COPD exacerbations. This gives great perspective as to really what works based upon many years of robust research, and this is all endorsed in the latest version of the Gold COPD guidelines. Note, good old albuterol is still alive and well. Look here at the top. There's our longtime friend. Still gives you that warm and fuzzy, doesn't it, when you see it in the orders? And it's still a part of the recommendations. Yes, we tend to overutilize antibiotics in our Western healthcare world, but for COPD patients, they are still part of the algorithm of care when indicated. And we have to mention BiPAP, non-invasive ventilation, is still the literal and figurative gold standard for COPD exacerbation with accompanying respiratory failure. But don't count out good old high flow oxygen in some of the patients. I thought this was pretty good. Many years ago, I did a stint in pulmonary rehab, and I used to really warmed my heart just listening to some of the banter among the circles of patients there. They were always competing with their oxygen devices. Some liked to be sicker than the other person. They were just always having a little competition. Okay, let's kind of apply some of what we've talked about here, and we'll slow it down a bit. So let's look at a few simple cases just to put into practice a bit of what we discussed so far. So you have very limited information here. Let's take a look. You've got Mr. Samuels. He's a 64-year-old male, so he's not elderly, but he's on the cusp of transitioning to that 65 or older age bracket. Incidentally, he's a non-smoker, but he presents to the pulmonary outpatient clinic after he gets referred from his primary care physician. He complains of worsening fatigue with the chief complaint of shortness of breath when he exerts himself. And he's got this nagging, dry cough. So you can see this patient isn't elderly per se, but is of a certain age that has likely allowed significant exposures to particulates over his 6+ decades of life. Recall that smoking history is not an absolute necessity to consider a COPD diagnosis. Although smoking, yes, it is still the most common risk factor, smoking doesn't have to be present for someone to develop COPD. There are environmental factors other than tobacco smoking that can contribute to COPD. This patient's fatigue in general could be an indication of a plethora of underlying issues, but keeping with our limited time today and the goal of today's topic, his fatigue could likely be due to just overall poor sleep quality from the coughing, generalized hypoxia, albeit mild. The persistent dry cough could be worst case scenario. Yes, it could be cancer, but a persistent cough, even with no expectoration, so a dry cough, or even if they had increased secretions, it just could be a sign of an underlying general mild inflammatory disease process. Maybe it's acute, maybe it's obstructive disease. But the patient certainly would need further diagnostic evaluation, such as spirometry, pre and post bronchodilator, a chest x-ray, maybe even a 6-minute walk test. And I would want to know more details about his overall clinical history. But resting sat is always important, but with mild exercise, it could also be helpful, maybe even an EKG if you're so inclined. Now, do recall before we move on to the next more detailed case that an FEV1 FVC ratio of less than 70 post bronchodilator is the so-called gold standard for diagnosing COPD. Of course, you've got to still have clinical history in mind, their symptoms, and you must consider all of it really before COPD diagnosis could be definitive. One last thing here, certain patients may be found with pre-COPD or PRISM. Remember, that's the preserved ratio impaired spirometry. They are at risk for developing airflow obstruction over time, but not all of them necessarily do. So this is a different case. You may have a little bit more information. I've got some diagnostics coming up for Ms. Sanchez here. So let's look at Ms. Sanchez. You that have been a clinician for any amount of time already recognize that this looks like maybe a typical COPD patient. Let's go through it. She's 55 years old, longtime smoker with a history of acute myocardial infarction quite a few years ago. She's had a CABG, coronary artery bypass graft, 3 vessels replaced, had open heart surgery. And she presents to the pulmonary outpatient clinic for a 3-month follow-up checkup. The patient reports recent hospitalization for pneumonia. Ooh, she's already back. Oh, it's just a follow-up visit. Let's see what else we have. She admits she sometimes forgets to take her breathing medication. It happens. And is currently still feeling weak with a productive cough. So as it stands at face value, this patient is at high mortality risk given the fact that, one, she has a significant cardiovascular disease history, along with a recent exacerbation, and self-admitted she's non-compliant. So let's look at her PFT. So same patient, let's look at her PFT. And I know this isn't a PFT-centered presentation, but let's quickly glance here and evaluate the patient's spirometry. Remember, baseline pre-bronchodilator is important, but even more so is do they respond to bronchodilator. So on the left-hand side here, labeled pre-exercise in our software, you have what she actually performed, her predicteds, and her percent predicted. Now for the right side of spirometry, also known as post-bronchodilator, post-treatment evaluation, recall that improvement in FEV1 or FVC individually of at least 10% would be considered a significant response. So here at the top, I see she increased 15% for FVC, 16% for FEV1. But let's start from the top here. If I look over to my left, I want to look for the gold standard indication of potential obstruction, COPD here. FEV1 FVC absolute value of 39%. Post-bronchodilator, there was no change. She's still at 39%. So trademark, gold standard, she definitely has COPD. Note only a change of 100 mils as opposed to the typical 200 requirement is necessary, but lower overall FVC, the percentage is the most important metric of change indication here, and she's got a increase of 15 and 16%. So she responded to bronchodilators. So dividing at left side is what she did at baseline. On the right side is post-bronchodilator study. Now, coupled with her general clinical history, depending upon her MMRC score, we would give her the questionnaire, maybe the CAT test, not too different from the St. George's. She is a gold category 3 for spirometry. Only category 4 will be worse because her FEV1% predicted is 30 to 49%. She falls into that range there. She's actually 47% predicted, but an absolute value of 39%. And you can see her flow volume loop. This is the outline of the predicted dots, very small for what it should be. She's putting out a decrease in flows. And it looks like we're taking off the runway here. She's still emptying out when the test ends right at 8 seconds. You only need 6 seconds for ATS criteria. Now, I know we're going through a lot here, but this is still Miss Sanchez. This is her chest x-ray. Notice the lungs are markedly hyperinflated with flattening of the diaphragms here. You can count her ribs down the list. The widest transverse process is always the first thoracic vertebral body, so that's a good landmark to know. As I count the ribs down, she's expanded almost all the way down to T12. There are bullous changes in the left upper lobe. You see she loses those interstitial vascular markings, and the heart has that elongated appearance. Yes, this patient meets all typical criteria for COPD diagnosis, but likely is presenting per chest x-ray with even an element of specific emphysema. So let's look at another short case here. This is Mr. Algohim. So immediately you notice we have two potentially significant risk factors. Let's look. He's 49 years old, but he's a 2-pack per day smoker, and he has an occupational exposure here. He's worked at a textile factory, and he's recently medically retired, remains on disability now, mind you, at 49 with worsening symptoms. He's being seen by the pulmonary specialist in the outpatient clinic for follow-up after multiple exacerbations, and he was hospitalized about 2 weeks ago. So immediately he's got the two potential risk factors that are significant. He's a smoker, and he has an occupational history here. Yes, most jobs per OSHA mandate personal protective equipment is indicated, but you'll find a large portion of workers rarely comply consistently, particularly in certain professions or environments, let's be honest. You can see that his CAT test, his COPD assessment test, renders a fairly high score. His score is actually 33 if you do the math, and his MMRC score is a grade 3. So he would be considered a fairly severe COPD case here. Let's look at his spirometry. Now, dividing it up into right and left, same as before. On the left-hand side, we have his baseline. On the right-hand side is post-bronchodilator study. Notice here that his actual FEV1 to FVC ratio does meet gold criteria for COPD, having it less than 70%. But there was no real significant post-bronchodilator response, as indicated by the less than 10% change in FEV1 to FVC. In other words, neither FEV1 or FVC increased by at least 10%. Interestingly enough, though, he went from a baseline of 68% FEV1 to FVC ratio, and after the post-bronchodilator challenge here, study, not really a challenge, his number actually dropped. So either way you look at this, he meets gold criteria for less than 70%. Now, putting it all together in consideration of clinical history and spirometry, along with subjective metrics, questionnaires, Mr. Algohim should be officially categorized as a gold 3, according to his spirometry. So not the most severe, but he's got a high indication of COPD-related impact to his quality of life, also known as health-related quality of life, with that 33 on his CAT test. And consider he also has a recent history of exacerbations and a hospitalization. So all in all, because of Mr. Algohim's multiple exacerbations, recent hospital admission for such, he would be a gold E category at 49 years of age. Think about it. He had the double exposures. Putting it all together, you can see here the Group E recommendations compared to the Group A and the Group B. The groupings are dictated by the degree of exacerbations and the MMRC and the CAT assessments. Now, we have limited time here today, but let's quickly overview just the specific treatment strategies between stable COPD and COPD exacerbations. It's worth noting that there are so many different varieties of specific medications among the categories that only categorical mention will be made here. You'll notice there isn't a great difference or dichotomy between the two types of COPD shown, but of course, exacerbations are treated a bit more aggressively. You have things like mechanical ventilation showing up on the exacerbation list, not so much, of course, on the stable list. Today's webinar timeframe will not allow us a deep dive into mechanical ventilation, but keep in mind that non-invasive ventilation is still the mainstay treatment for COPD exacerbation, as well as invasive when it is indicated. Just a few key items for reference, and so you will have at your fingertips at the conclusion of this presentation. Here is a general list of important notables for O2 therapy with a sprinkling of ventilatory support items. It's a great reference. Notice to the left, the chart applies to stable COPD. And we can all use a refresher on the infamous oxygen prescription. Well, here it is. The chart to the right is a very nice summary of how to steer supplemental O2 and the decisions thereof for COPD patients. I realize this is a very busy chart, but arguably one of the most important concepts of today's broad topic is what works? What works? What is the evidence of what works? Concentrate primarily on the far left, where both medication intervention and non-medication intervention is highlighted per the evidence. They're all based upon these well-designed randomized control trials. This is the stuff that works. Combo therapies, smoking cessation, pulmonary rehab, long-term oxygen therapy when indicated, and non-invasive even when needed. And even lung volume reduction surgery in patients that have a significant specific type of emphysema. So in closing here, just some things to leave you with to think about. We're not shooting for the stars when it comes to the SAT for a COPD patient typically, especially those with more severe conditions or diseases. You should check ABGs frequently, but not everybody needs an ABG. And yes, consider high-flow oxygen or non-invasive in addition to standard O2 therapy, and sometimes you're avoiding intubation or maybe they're DNI, DNR. Some patients need to be admitted to a higher level of care with immediate ventilatory support. So keep in mind, everyone, of course, is different depending on their history and how they present. In general, this is the grand overview of COPD management. You can see that diagnosis is multifactorial as well as initial assessment considerations. Very important. The crux or framework for COPD management, again, is going to be proper and accurate diagnosis. Thereafter, symptom management and exacerbation prevention is the key. If you're interested in much more and so inclined, near the end of this year, the International Conference for Gold COPD is coming to Philadelphia as it does every year, and you can go to the Gold website for more information. Leave you with some food for thought, directly quoted from the latest Gold Guidelines Comprehensive Report. Yes, COPD is preventable. It is treatable. It's immensely underdiagnosed, and a lot of times misdiagnosis leads to patients receiving no treatment or the wrong treatment. There are environmental factors that play a role other than just tobacco smoking, which can contribute to COPD, and it can even start early in life and affect young individuals. We're seeing more and more patients in their 30s even with significant exposures that have COPD by definition and diagnostic criteria. Thank you for your attention. I'd love to take any questions you have, and I will also watch the chat if that is your preference.